Dear Chairman, dear colleagues, I'm really honored to participate in this exciting meeting, and I would like to thank the organizing committee and Dr. Kochis for the kind invitation. So, dear Chairman, as you mentioned, the topic of my presentation is the ideal, if it exists, of course, antithrombotic treatment in patients with coexisting atrial fibrillation and renal disease. These are my disclosures. And I will start with a definition. Chronic kidney disease is defined as kidney structure or function abnormality present for more than 3 months. And in terms of laboratory value, a very reliable index is eGFR. So patients with an eGFR below 60 are considered to have renal impairment. But in randomized controlled trials of FOAC for stroke prevention in AF, renal function was usually estimated using the Cockcroft-Gault formula for creatinine clearance. Therefore, patients with a creatinine clearance above 80 are considered to have a normal renal function. Those who have 51 to 80 mild renal impairment, 30 to 50 moderate, 15 to 30 severe renal disease, and those who have a creatinine clearance below 15 have end-stage renal disease and are usually maintained on dialysis. Chronic kidney disease is by definition a both prothrombotic and prohemorrhagic state. Prothrombotic because it activates Virchow's triad through accelerated atherosclerosis, through atrial dilation, and through increased coagulability. And prohemorrhagic state because due to the accumulation of uremic toxins and metabolic compounds, it causes alterations in platelet function, alterations in platelet vessel wall interactions, and activates also the coagulation cascade. If we also take into account that patients with chronic kidney disease have coexisting AF in almost 20% of cases, then we need to be extremely careful and to balance the risk of bleeding versus the risk of stroke prevention when considering about the recommended antithrombotic drug that we should use in these patients. And until recently, warfarin was the gold standard treatment for patients with AF until the emergence of DOACs, which proved to be at least as safe, but better in terms of efficacy when compared to warfarin, of course, in patients with AF. But this accounts for the total population. So the question is, do we have data about patients with renal disease? And actually, we do have data for patients with mild to moderate renal disease coming from the randomized trials. And the first study is the RELY study, which compared dabigatran versus warfarin in AF patients. And here you can see the results according to the renal function, both estimated by the Cockcroft-Gault formula and the chronic kidney disease EPI equation. So in both formulas, as you can see, in terms of stroke or systemic embolism, there was no interaction between treatment and renal dysfunction with respect to efficacy. And as you can see, in terms of safety, there was a significant interaction between treatment and renal subgroup with regard to major bleeding. What does this mean? It means that dabigatran, the patients who benefit more from dabigatran in terms of safety are those with GFR above 80. And this, of course, could be a chance finding because these are subgroup analysis, but it could also be attributed to the increased renal excretion of dabigatran, which is approximately 80%. These are the results from the Rocket AF, which compared rivaroxaban versus warfarin in almost 14,000 patients. 20% had a moderate renal disease. And I would like also to point out that in this trial, as well as in the RELY and the ENGAGE-AF trial, patients who had a creatinine clearance below 30 were excluded. But as you can see in this slide, patients were categorized either to creatinine clearance above 50 or to creatinine clearance 30 to 49. And there was no treatment, there was no interaction between treatment and the renal impairment with regards to safety or efficacy. And that means that rivaroxaban was non-inferior to warfarin, irrespective of renal function in terms of stroke prevention and of major bleeding. Edoxaban in the ENGAGE-AF TIMI trial also categorized patients according to renal function, either to creatinine clearance above 50 or to creatinine clearance 30 to 50. And these are the results for the high dose of edoxaban, where you can see that irrespective of the renal subgroup, there was no difference between high dose edoxaban and warfarin in terms of stroke prevention. And high dose edoxaban seemed to be safer than warfarin in terms of reducing the major bleeding risk, irrespective of the creatinine clearance. Aristotle compared apixaban versus warfarin, and it's the only trial that included patients with a creatinine clearance up to 25. And these are the results where, according to the renal impairment, as calculated with 3 methods of GFR equation, Cockcroft-Gault, chronic kidney disease EPI, and cystatin eGFR. And as you can see, no interaction between treatment and a renal subgroup with regards to efficacy. But in terms of safety, there is significant heterogeneity between the renal subgroups. And that means that patients who benefit more from apixaban are those who have a creatinine clearance or eGFR according to chronic kidney disease EPI formula below 50. And of course, again, I don't have a very clear explanation for this. This could be a chance finding, but also it could be attributed to the very low renal clearance of apixaban, or to the very steady pharmacokinetic profile, at least compared to warfarin. Do we have data about patients with severe renal disease, and that is a clearance of 15 to 30? Actually, we do have data coming from one only randomized trial, the Aristotle trial. And here you can see the results where patients were categorized either to a creatinine clearance above 30 or to creatinine clearance of 25 to 30. And you can see that patients who belong to the low creatinine clearance category seemed to have even less bleedings, major or non-major, compared to those who had a higher creatinine clearance. So apixaban seems to be safe, safer than warfarin, even to these patients with severe kidney disease. And of course, we have real world data coming from a very large database, US database. And here you can see one of these studies with almost 35,000 patients who had a GFR of 15 to 35. And if you focus on the eGFR 15 to 30, you can see that in terms of stroke prevention, apixaban and rivaroxaban had similar rates of strokes compared to warfarin. And in terms of major bleeding, all 3 DOACs, apixaban, dabigatran, and rivaroxaban, had low and comparable rates of major bleeding compared to warfarin. What about patients on dialysis? I think that first we have to answer one question about these patients. Do they really need to be anticoagulated? Of course, the guidelines suggest that all patients who have a CHADVA score of 2 or more should be anticoagulated. But in these patients on dialysis, there are some observational studies that suggest that the oral anticoagulants versus no anticoagulant does not offer any protection, any significant protection with respect to thromboembolic events. On the contrary, anticoagulants increase the risk of major bleedings. So there are some studies which will address this issue, and this is one of these studies, the atrial study, a randomized interventional study, phase 4, which will randomize 855 patients to either no oral anticoagulation or oral anticoagulation with a vitamin K antagonist. All patients are on hemodialysis, and we expect that the results, the study will be completed by the end of 2022. Until then, we have data coming from DOACs. And this is the first study to assess the safety of dabigatran and rivaroxaban in patients with AF on hemodialysis. This is a cohort study of 280 patients on dabigatran and 244 patients on rivaroxaban. This is the first study that was published, and patients on DOACs were compared with 8,000 patients on warfarin. And as you can see, both rivaroxaban and dabigatran were independently associated with significantly higher risk of bleedings, of hospitalizations, and deaths. But it should be noted that patients who received the low dose of rivaroxaban, and that is the 15 milligram per day, had lower and comparable rates of major bleedings compared to warfarin. So the question is if the increased incidence of bleeding with DOACs in this cohort could possibly be due to subtherapeutic anticoagulation in the absence of appropriate dose adjustment of rivaroxaban, or perhaps a warfarin comparison group that spent most of their time in the subtherapeutic range. In this context, there was another trial which assessed apixaban use in end-stage kidney disease in patients with AF in the United States, published from Dr. Siontis. These was eligible patients were those with end-stage kidney disease and AF undergoing dialysis who initiated treatment either with warfarin or a DOAC. Unfortunately, few patients received rivaroxaban and dabigatran, so the comparison was between apixaban and warfarin in matched cohorts. And here we can see that the overall population was 25,000 patients, and approximately 2,000 patients received apixaban, half of them in the full dosage and half of them in the reduced dosage. And these are the results, where you can see that there was no difference between the apixaban group and the warfarin group in terms of stroke. However, patients who received apixaban had significantly fewer major bleedings compared to warfarin, and no difference also in deaths. In a sensitivity analysis, patients who received the full dosage of apixaban, and that is 5 milligram twice daily, had significantly fewer strokes and deaths compared either to apixaban low dosage or warfarin. So the conclusions from this trial was that apixaban may be associated with superior safety and effectiveness outcomes in the population of coexisting AF and end-stage kidney disease on dialysis as compared with warfarin. And while both standard and reduced apixaban doses were associated with lower major bleeding risks compared with warfarin, only the standard 5 milligram dose daily was associated with reduced thromboembolic events and mortality. However, these findings required further investigation and confirmation in randomized controlled trials. And based on the latter statement, the investigators designed a randomized trial, the renal AF trial, which aspired to randomize 760 patients with AF on hemodialysis, either to apixaban in the dosage of 5 milligram twice daily, or to warfarin, and the primary outcome was bleeding, either major or non-major. Unfortunately, this trial was prematurely ended because of a low recruitment rate. Only 150 patients were recruited, and among them, 77 received apixaban, and 70% received the full dosage, and 28 received the the low dosage of apixaban. Another limitation of this study was the low TTR in the group of warfarin, which was only 44. And here you can see the results. Apixaban had similar rates of major or non-major bleedings compared to warfarin, with a hazard ratio of 1.2. And the bleedings were mainly coming from the hemodialysis access site. And also one could note that patients who received apixaban had almost 1/3 only of the gastrointestinal bleedings compared to patients who received warfarin. The conclusions from the renal AF trial was that in this exploratory study, there were similar rates of major and clinically relevant non-major bleeding with apixaban and warfarin, and more data are needed to guide care for this high-risk population. So until we have more data, where do we base our clinical practice? And one could say that we could base our, can have a guidance from the big meta-analysis. And this is one of them, a very recent one, which included all the randomized trials that I presented, 7 randomized trials and 10 observational studies, which include patients with AF, a GFR of 17 to 60, and compare DOACs versus warfarin. And as you can see in the first column, patients who received a DOAC have significantly fewer thromboembolic events compared to those who received warfarin, with a relative risk reduction of 14%. And in the right column, you can see the results in terms of safety of bleedings. So patients who have AF and a GFR of in the range of 15 to 60, when they receive DOACs, have significantly fewer bleeding events compared to those who receive warfarin, with a relative risk reduction of 19%. What about patients on dialysis? As I said, we have only 2 observational studies, so we can not have any robust conclusions. But if we want to say something about these patients, we can say that apixaban reduces the bleeding events compared to warfarin, whereas the bicadran and rivaroxaban increases the bleeding rates. And in the hot question, which DOAC is the best? We cannot say which DOAC is the best. There is also indirect comparisons in these patients, and this, of course, it comes from this meta-analysis. With a green color are the data regarding safety. So we could say that it seems that two of the most safe choices in these patients with a creatinine clearance between 15 to 60 are the dose-adjusted apixaban or the low dosage edoxaban in the 15 milligram. And one of the, let's say, more efficacious choices in these patients is the bicadran in the high dose, apixaban in dose adjusted, and edoxaban in the high dose regimen. And these are the results. Only 2, the main key findings from this meta-analysis are that DOACs are superior to warfarin in AF patients with GFR 15 to 60. They reduce the relative risk of thromboembolic events by 14%, and the relative risk reduction in the bleeding events is approximately 19%. And dose-adjusted apixaban and edoxaban in the low dose seem to be superior to other DOACs in terms of safety. And these findings were actually, in a way, captured in the guidelines. These are the American guidelines, which suggest that in patients who have end-stage chronic disease, it might be reasonable to prescribe either apixaban or warfarin. However, this was not captured in the European guidelines, which suggest that all DOACs should be contraindicated in patients with dialysis. And in those who have a creatinine clearance between 15 to 30, the low dosages of rivaroxaban, edoxaban, and apixaban could be recommended, and dabigatran is contraindicated. There is some ongoing research in patients with renal disease, and Among them is Axadia, the safety and verdict. And very briefly, Axadia will assess the safety of apixaban versus VKA in patients with AF and end-stage kidney disease on hemodialysis. And the verdict is very interesting trial because it's one of the few trials which will assess the reduced doses of apixaban and rivaroxaban compared to standard of care in VT patients with moderate or severe renal insufficiency in terms of clinical benefit. So dear chairman, dear colleagues, the take-home messages from my presentation are that all four drugs can be used in moderate chronic kidney disease at the recommended dose. Dabigatran, rivaroxaban, and edoxaban should be used in a reduced dose, and apixaban in a standard dose. In severe kidney disease, a creatinine clearance of 15 to 29, apixaban, rivaroxaban, and edoxaban might be used with caution in a reduced dose where dabigatran is contraindicated. There are no high-quality data for DOACs in patients with end-stage renal disease. European recommendation contraindicate the use of all DOACs in patients with eGFR below 15 or an hemodialysis, whereas the FDA allows for apixaban use in those cases, and data on whether DOACs or warfarin reduce the incidence of stroke compared with no treatment in patients with end-stage renal disease is inconclusive. I would like to thank you, and I am more than